স্যার আমরা এখন লাইভে আছি।
Okay. Assalamu alaikum. Good evening, everyone. It's a great pleasure to welcome you all in the tonight's program of NHF cardiac course. Today's topic of discussion is probably the most important in the field of cardiology because almost all the disease of the heart, whether it be ischemic, structural, valvular, myocardial, pericardial, or hypertensive, ultimately ends up in heart failure. All the burden of heart disease ultimately results in the failure of the heart to pump adequately. So today we are really feel honored and privileged to have with us National Professor Brigadier Abdul Malik sir, a founder and president of National Heart Foundation of Bangladesh and former advisor to caretaker government. We welcome you, sir, in our program. And we also have with us two eminent cardiologists of Bangladesh, Professor Sajal Krishna Banerjee, Dean Faculty of Medicine and Professor and Chief of Cardiology, Bangabandhu Sheikh Mujib Medical University. Probably due to some personal reasons, he will not be able to join us. We also have with us Professor Dr. Chaudhry Meshkat Ahmed, Professor of Cardiology, Bangabandhu Sheikh Mujib Medical University, very academic and honest critic of knowledge. Welcome, Dr. Meshkat. And we have four very talented speakers with us. They will discuss different aspects of today's topic. Before we start, may I request Brigadier Professor Abdul Malik sir to make some opening remarks.
Thank you. Bismillahirrahmanirrahim. Professor Rahiduzzaman and other respected faculties and participants, Assalamu alaikum. I am very happy to be here in this evening in this important topic which you are arranged, heart failure. As you have told, all roads lead to Rome, means any heart disease can lead to heart failure. And particularly in this age, when people are going gradually, longevity is increasing, so there is more chances of heart failure. And this will be really a problem for future cardiologists. Because once somebody has got heart failure, chronic heart failure, it is become chronic and it is definitely a burden to family, society and the nation. You will have to manage them properly, keep them in working condition, and the heart failure, physiology, pathology, and also mechanism and treatment. One should know how it happens. I am sure today the distinguished speaker will speak over this, and I will tell the participant to think over it. And whenever you are using any medicine, you must know all the drugs used in cardiology are potentially dangerous. So whenever you use, you must know why and how you are using. Sometimes there is a term, intractable heart failure. And I have seen in many cases, intractable heart failure means you are not probably treating the patient properly with adequate doses. So overdose is bad, underdose is bad. And why you are giving, you should know it. So you should think about it and give the medicine not by memory. So please utilize the time, learn it, and utilize your knowledge with conscience so that you do not do any harm to anybody. If you do not understand something, please consult one of your friend or senior colleague because you should not do any harm to anybody. Thank you very much. I hope this will be very useful for every one of it. There is no end to learning, and you will see a lot of changes going on. In our ages when we started our medical practice, at that time there was no diuretic, nothing you see. Treatment was different. And probably after a few years, there will be a lot of changes going on gradually. So try to keep your knowledge abreast and do good to people. Thank you very much. And I like to leave you. Thank you very much. Thank you very much. Thank you.
Thank you, sir. Thank you very much for your valuable speech. I think sir will leave us because sir was very tired today. He attended a long meeting with the ministry.
Thank
So,
you
with
very much.
thank you, sir.
Thank you very much.
So, thank you, sir. So, with the permission of other panelists, may I start the session, Fazilapa? So, our first speaker is Dr. Shamim Chaudhry. He'll be speaking about the definition, pathophysiology, and classification of heart failure. Dr. Shamim Chaudhry, please share your screen.
I'm audible, sir.
You are audible.
Audible and visible.
Honorable National Professor Brigadier Abdul Malik, sir, Professor Fazila Malik, madam, respected moderator, and panel of expert and distinguished participants. Assalamu alaikum. My topic of presentation will be definition, classification, and pathophysiology of heart failure. Heart failure may be defined very simply as when heart cannot maintain adequate cardiac output and circulation to meet the demand of the tissues. However, in other words, heart failure can be defined as a complex clinical syndrome resulting from structural and functional impairment of ventricular filling or ejection of blood. Worldwide, heart failure affects almost 23 million people with the economic burden of 108 billion US dollar, and 50% of heart failure patients die within 5 years from the diagnosis, and it is the #1 cause of hospitalization among the patients aged more than 65 years. And the vast majority of heart failure patients has 3 or more comorbidities like the COPD, anemia, diabetes mellitus, hypertension, angina, renal dysfunction, and sleep apnea. However, there is paucity of data regarding the heart failure in Bangladesh. In a hospital-based retrospective study was done in a National Heart Foundation Hospital between the January 2005 to August 2006 by Rahiduzzaman et al. Under the guidance of Professor Malik sir, which showed that about 1/7 of the patients admitted had heart failure. That was the 14.1% of totally admitted patients. Mean age of the hospitalized heart failure patients were a little bit lower, that is 54.1 to 15.3 years, which was a bit higher in European studies, with higher prevalence in male than female. And coronary heart disease is the main cause of the heart failure with the 35.79%, followed by the valvular heart disease, that is 22%, whereas hypertension and diabetes mellitus is the primary risk factor. Chronic heart failure patients were more prevalent among the patient population, that is 71.3% versus 28.7% of acute cases. Among the congenital heart diseases, ventricular septal defect and patent ductus arteriosus were most common cause of heart failure. Mortality rate of the study population were 9.7% and higher in male. Now, classification of heart failure is very diverse. It can be classified according to the involvement of the chamber. There are functional classification, assessing staging of heart failure, according to the ejection fraction, according to the time course or onset of heart failure, and there is CLIP classification for post-myocardial infarction risk stratification. According to the involvement, there are left heart failure, right heart failure, or biventricular failure. There is a term that is cor pulmonale, which is used either to describe right heart failure, secondary to chronic lung disease with or without right ventricular hypertrophy. Left heart failure has some subtypes also, like forward failure and backward failure, and high output failure or low output failure. And there is a New York Heart Association functional classification to see the status of the patient. There is a class 1 has no limitation of physical activity. Ordinary physical activity does not cause symptoms of heart failure. And class 2, there will be slight limitation of physical activity. Ordinary physical activity results in symptoms of heart failure, but patient will be comfortable at rest. Class 3, there will be marked limitation of physical activity. The less than ordinary activity will cause symptoms of heart failure, but patient will be comfortable at rest. Class 4 is the symptoms at heart failure at rest, and unable to carry on physical activity without symptoms of heart failure. This is a SSA-AHA staging of the heart failure. It has 4 stages. Among that, stage A and B are those patients who are at risk for heart failure, and stage C and D are the overt heart failure. Stage A are those patients who are at high risk for heart failure but without structural heart disease or symptoms of heart failure, like the patients with hypertension, diabetes, obesity. Stage B is a structural heart disease but without sign and symptoms of heart failure, like the previous myocardial infarction, left ventricular hypertrophy, asymptomatic valvular heart disease. This can progress to the symptoms, that is the stage C heart failure, that is structural heart disease with prior or current symptoms of heart failure. And the stage D is the refractory heart failure, that requiring specialized interventions. And this is another pictorial showing the pyramid of the an association of NYHA classification with SSA-AHA staging. That is done by the Olmsted clinical survey of the heart failure. It shows very strange, exciting result, that is on stage A and B have no NYHA classification, that their functional status is okay, but these groups stage A and B have majority of the patients with the stage A are the 50 to 60 million patients. Another classification by European Society of Cardiology 2016 guideline, it was based on the ejection fraction, that is heart failure with preserved ejection fraction, heart failure with mid-range ejection fraction, and heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction are those patients who have LV ejection fraction less than 40%. Heart failure with mid-range ejection fraction are LV ejection fraction 40 to 49%, and heart failure with preserved ejection fraction is left ventricular ejection fraction more than is equal to 50%. However, they are heart failure mid-range and preserved ejection fraction are associated with some other criteria like elevated natriuretic peptides and at least one additional criteria like relevant structural heart disease or diastolic dysfunction. Heart failure mid-range ejection fraction are those patients either they could deteriorate from heart failure preserved ejection fraction, or they can shift from heart failure reduced ejection fraction either by management like revascularization or medical management or device therapy. Now, according to the time course or onset of heart failure, it can be classified as acute heart failure, chronic heart failure, and there is a new term, that is chronic stable heart failure, that was termed as a treated patient with symptoms and signs that have remained generally unchanged for at least 1 month. And another one is worsening or decompensated heart failure, that is sometimes was termed as acute decompensated heart failure. The CLIP classification was done to see the 30-day mortality post-myocardial infarction patient in revascularization era. CLIP class 1 has no evidence of chronic heart failure. CLIP class 2, there will be raised JBP or gallop, and class 3 will be pulmonary edema, and class 4 will be cardiogenic shock. Now, as a heart failure is a progressive disease, when we see the patient, that is too late for us, that is patient has developed symptoms, but we can change this scenario either by early intervention like risk factor modification, or by evaluation by biomarkers or echocardiography to evaluate the systolic or diastolic dysfunction, or evaluation for coronary artery disease or left ventricular hypertrophy. Now, etiology. Regarding the etiology, it can be classified according to the mechanism of heart failure, like reduced ventricular contractility, such as myocardial infarction or myocarditis or cardiomyopathy, ventricular outflow tract obstruction, like hypertension or aortic stenosis, pulmonary hypertension, pulmonary stenosis, ventricular inflow obstruction, mitral stenosis, tricuspid stenosis, diastolic dysfunction, constitutive pericarditis. Ventricular volume overload in a situation like mitral regurgitation, aortic regurgitation, or atrial septal defect or ventricular septal defect. Arrhythmia can cause also heart failure either by tachyarrhythmia or bradyarrhythmia. Now, pathophysiology. Pathophysiology, not a single mechanism can explain the pathophysiology of heart failure. It is very complex pathophysiology. first of an index event either by cardiac or extracardiac injury, it will activate the neurohormonal activation, and that will lead to the remodeling of the left ventricular myocardium, which will interconnect each other and progress to the heart failure. That is another pictorial showing after the index event the changes in the heart. There is some secondary changes, neurohormonal activation like sympathetic system activity and RAS system activation and endothelial dysfunction, which leads to the progressive heart failure that causes some compensatory mechanisms like vasoconstriction and sodium and water retention, which leads to the increase after load and increase in intravascular volume. And this chain reaction goes and patient develops the progressive heart failure, that is chronic heart failure. And this is another diagram showing the graphical presentation of Frank-Starling relation with the heart failure. In a normal heart, usually there is a steep and positive relationship between the preload and stroke volume or cardiac output. There is increase in preload, there will be increase in the cardiac output. However, in case of heart failure, like in the mild dysfunction or stage A and B dysfunction, the patient will achieve the cardiac output in spite of increased LV and diastolic filling pressure. But in case of severe dysfunction, increase in preload or LV and diastolic pressure or filling pressure will not increase the cardiac output. However, from mild dysfunction, it can improve either by the use of diuretics or by the evidence of fluid retention. And this is a picture showing the mediators released in heart failure. Among these, the myocardial stress is the key factor to release the most important mediator, that is natriuretic peptides. It is a very important for prognostic and diagnosis of heart failure. There are three types of natriuretic peptides: atrial natriuretic peptides, B-type natriuretic peptides, and C-type natriuretic peptides. B-type natriuretic peptides are again has two parts, that is active BNP and N-terminal pro-BNP. These peptides are considered counter-regulatory because they tend to reduce right atrial pressure, systemic vascular resistance, aldosterone secretion, and sympathetic nerve stimulation, and can enhance sodium excretion, that is natriuresis. This is of importance due to some reasons, like there is a enzyme, that is neprilysin, which inactivates these natriuretic peptides. There is a new drug called secuvitril which inhibits this enzyme so that natriuretic peptides remain active, so that this counter-regulatory function goes on and patient may benefit from this. Another entity is the heart failure with preserved ejection fraction. It is now assumed that it is the 50% of the patients of heart failure have normal ejection fraction. However, it was previously said that it was diastolic heart failure or diastolic dysfunction heart failure. But nowadays, it is termed as heart failure with preserved ejection fraction, because only diastolic dysfunction cannot produce heart failure with preserved ejection fraction. LV relaxation and filling abnormality is a factor for heart failure with preserved ejection fraction. However, LV and left atrial structural remodeling, skeletal muscle and endothelial function, and change in the LV and systemic and pulmonary vascular compliance, and inflammatory signaling and profibrotic signaling are the key factors for development of HFpEF. There are some etiologies for the HFpEF patients, like the lung diseases, left ventricular diastolic dysfunction, atrial dysfunction, autonomic dysfunction, diabetes, hypertension, obesity, aging, and renal dysfunction, anemia. Another entity is the acute heart failure. Acute heart failure can be either de novo dysfunction of previously normal heart or acute worsening of known chronic dysfunction, which can be due to vascular endothelial dysfunction or due to neurohormonal activation or cardiorenal syndrome or inflammatory or oxidative stress. Thank you all for patient hearing.
Thank you, Dr. Shamim. So I think we should keep our question answer session after completing.
I think that's a good idea because we want to keep in time And
So we'll talk. Okay, then our next speaker will be Dr. Rahiduzzaman, Associate Professor of Cardiology. He will be talking about clinical feature and diagnosis of heart failure. Dr. Rahiduzzaman, please.
Okay, sir. Thank you. So my screen and me is audible or visible?
Yeah, you're audible, you are visible.
Okay, thank you. So with due respect to all and salam to all and praying in safe and prosperous days for all in this COVID era, I'm going to talk about the clinical features and diagnosis of the heart failure. Initially, I want to state that in spite of invention of all the modalities for diagnosis of heart failure, still it is the clinical diagnosis that remains the gold standard for diagnosis of heart failure. So my topics is clinical features and diagnosis. So approach to a patient of heart failure, a complete medical history, carefully focused physical examination are the foundation of assessment of heart failure patient. These two are very important for diagnosis. And medical history and physical examination will provide information regarding etiology of the heart failure, identifying possible exacerbating factor, leading pivotal data for proper management, guide the further direction of patient's evaluation, enable the clinician to make the most judicious use of additional tests. And this one slide, I want to have it was the first slide in my life that constructed with my imagination. In our previous starting of this session, our beloved and respected Professor Malik Sir cited that all road leads to Rome. Actually, that thinking I have implanted there, that all the causes of heart diseases ultimately lead to heart failure. As like all the waterfalls and rivers ultimately drains into sea to be evaporated for infinity. Actually, heart failure, it leads to be evaporated for infinity. We want to just delay the evaporation. And I have seen some of the speakers using this slide. I am grateful to them. Now, the symptoms of heart failure. Patient may complain of vast array of symptoms like fatigue, shortness of breath, dyspnea, tachypnea, cough, diminished exercise capacity, orthopnea, paroxysmal nocturnal dyspnea, nocturia, weight gain, edema, increasing abdominal GERD, abdominal pain, loss of appetite, sin-stroke respiration, somnolence or diminished mental activity. But some of the symptoms are important like dyspnea and fatigue. So I will highlight some of the features, not all. None of the symptoms are entirely sensitive or specific for identifying the presence of severe congestion. These are fallacies, but some are more reliable than others for indication. Importantly, none is specific to heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction. Now, regarding the dyspnea is a cardinal symptom of heart failure, typically related to increased cardiac filling pressures. Dyspnea at rest has high diagnostic sensitivity and prognostic ramification. Breathlessness on lying flat, orthopnea, is usually associated with the left ventricular failure. And patients with acute pulmonary edema usually prefers to be upright. Now, regarding the fatigue is another cardinal symptom of heart failure, reflective of reduction in cardiac output and abnormal skeletal muscle metabolic response to exercise. Regarding the sin-stroke respiration, it is usually common in advanced heart failure and indicative of adverse prognosis. Now, the symptoms of the right heart congestion are weight gain, increasing abdominal GERD, early satiety because of liver congestion, onset of edema in the dependent organs like extremities and scrotum, right upper quadrant pain due to liver congestion. Now the physical findings of heart failure. There is a very good list of physical findings like tachycardia, extra beats, narrow pulse pressure or thready pulse, pulsus alternans, tachypnea, cool and mottled extremities, elevated jugular venous pressure, dullness or diminished breath sounds, rales, rhonchi, wheezes, apical impulse, displaced leftward and or inferiorly sustained apical impulse, parasternal lift, third or fourth third sound, tricuspid mitral regurgitation, murmur, hepatomegaly, ascites, presacral edema, anasarca, pedal edema, chronic venous stasis changes. I will highlight some of the important physical findings. So the physical findings complement the information from the medical history in defining the presence and severity of heart failure. And first of all, you have to give your attention for patient's general appearance and measurement of vital signs in seated and standing position, and examination of the heart and pulse, assessment of the other organs for evidence of congestion and hypoperfusion, and obviously you have to assess the comorbid conditions. So from patient's general appearance, you will get some vital information like body habitus and state of the alertness should be assessed, whether the patient is comfortable, short of breath, coughing, or in pain. Skin examination may show pallor or cyanosis resulting from underperfusion. Regarding cardiac impulse, the palpation of the apical impulse lead to rapid determination of the heart size and quality of the point of maximal impulse. Regarding the auscultation, murmur is a crucial part of heart failure evaluation, and characteristics hollow systolic murmur of MR is heard in many patients, and tricuspid regurgitation can be differentiated from murmur by evaluating the visibility of the V wave in the jugular venous pressure. Now, regarding the aortic stenosis, there will be some fallacy. The intensity of the murmur of aortic stenosis depends on blood flow across the valve, which may be reduced as heart failure develops. Now, auscultation of the third heart sound, it is a crucially important findings and suggests increased ventricular filling volume. While difficult to identify, it is a highly specific for heart failure and carries a substantial prognostic meaning. Regarding the fourth third sound, the presence of S4 usually indicate the reduced ventricular compliance. Now the summation gallop, what does it mean? In advanced heart failure, the third and fourth third sounds may be superimposed, resulting in summation gallop. Now the key objective of examination of the heart failure patient is to evaluate the volume overload and to detect and quantify the presence of volume retention with or without pulmonary congestion and systemic congestion. These are the key points. So congestion may occur in two different circuits or simultaneously in two circuits. One is the pulmonary circuit, another is the systemic circuit. This is very important for management purpose. Now regarding the volume overload, HAP-PEP and HAP-REP. Patients with heart failure with preserved ejection fraction and reduced ejection fraction do not generally show significant differences in frequency or significance of stigmata of volume overload. Now, the assessment of the volume overload by measuring the JVP, jugular venous pressure, and this measurement is most definitive method for assessing patients' volume status by physical examination. And the volume overload of pulmonary congestion that is exceedingly common in heart failure, and it is manifested as pleural effusion and leakage of fluid from pulmonary capillaries into the alveoli. So the pulmonary congestion, that is volume overload in pulmonary circuit, can be clinically or physically found as rales, rhonchi, and wheezing. Note, wheezing may result from reactive bronchospasm. Now, importantly, rales and rhonchi may be absent in congested patients with advanced heart failure. This may reflect compensatory increases in local lymphatic drainage. So this is important. Now, there's some term cardiac asthma is caused by physical presence of fluid in the bronchial wall as well as secondary bronchospasm. Caution, it can result in incorrect diagnosis of obstructive airway disease exacerbation. So be careful about it. Now, volume overload in heart failure, that is been manifested as lower extremity edema. These are common finding in volume overloaded heart failure patients. But other causes of lower extremity edema should be sought out, like venous insufficiency, side effect of medication, and careful inspection of jugular venous pressure helps improve the specificity of pedal edema in heart failure. Now, the physical findings in heart failure to evaluate the reduced cardiac output and systemic hypoperfusion. So reduced cardiac output and systemic hypoperfusion, detecting reduced cardiac output and systemic hypoperfusion are key component of examination. So what does it mean by systemic hypoperfusion? So it can be evaluated by patients with poor systemic perfusion, usually have low systolic and narrow pulse pressure, as well as weak and steady pulses. But this relationship is not exact. Many patients with systolic blood pressure in the range of 80 millimeter or even lower may have adequate perfusion, whereas others with reduced the expense of tissue perfusion by increasing the systemic vascular resistance. So the findings suggesting reduced cardiac output are poor mentation, reduced urine output, mortal screen, cool extremities. Of these, the cool extremities are the most broadly useful marker to decide about the reduced cardiac output. So these are the physical findings on behalf of congestion, and these are the physical findings on behalf of low perfusion. In favor of congestion, that is orthopnea, elevated jugular venous pressure, pulmonary rales, S3 gallop edema. And in favor of low perfusion, narrow pulse pressure, cool extremities, and hypotension. So now you have to interpret all the findings, like if it is on the basis of the systemic congestion and reduced cardiac output, the patient may be dry and warm. That means uncongested with normal perfusion, wet and warm, congested with normal perfusion, dry and cold, uncongested with hypoperfusion, wet and cold, cardiogenic shock. These have some management issue. So this is important. And I think this will be discussed by Abida. Now the investigations. These are list of investigation. Among these, the colorful ones are practiced in our day-to-day daily practice, like ECG, chest radiography, blood chemistry, hematology variables, and echocardiography. Regarding the ECG, is a standard part of initial evaluation of patient with suspected heart failure. It may provide important clues regarding incident heart failure. And in patients, heart failure patients, the ECG infrequently normal, but it may show non-specific findings. Note that all causes of heart failure will lead to heart failure. Heart diseases will lead to heart failure. So ECG will reflect the etiologic factor of the disease of individual patient, as well as features of the hemodynamic, decompensations, and arrhythmias. Sinus tachycardia caused by sympathetic activation in advanced heart failure or during episode of acute decompensation. Atrial arrhythmias as well as ventricular response may provide clues to the cause of heart failure. AF with fast ventricular rate in mitral valve disease is an example for exacerbating the heart failure. Evaluation of the QRS complex becomes a critical part of clinical assessment of CRT implantation and QT interval over prolonged electrolyte abnormality, myocardial disease, effect of drugs. And a lengthened QT interval may identify patients at risk for Torsades de Pointes. Now, regarding the chest radiography, should be a routine part of the early evaluation of patient presenting with symptoms suggestive of acutely decompensated heart failure. And results of X-ray chest are additive to the clinical variables from history and physical examination and complement the results of biomarker testing. So classic X-ray pattern in patients with pulmonary edema is a butterfly pattern of interstitial and alveolar opacities bilaterally fining out of the periphery of the lungs. And this is the classical example of the alveolar edema butterfly shape. There are other chest X-ray. Many patients present with subtler findings of increased interstitial markings, that is curly B lines. These are thin horizontal linear opacities extending to the pleural surface caused by accumulation of fluid in the interstitial space. And this is the example of the curly B line. Thank you, Dr. Shamin, for providing me this wonderful, nice slide. Now, X-ray chest, many patients present with evidence of prominent upper lobar vasculature indicating pulmonary venous hypertension. And this is the example of the upper lobar diversion, the pulmonary venous hypertension. Many patients may present with pleural effusions, fluid in the right minor fissure. But important note and caution is that many patients, particularly with advanced heart failure, the chest radiography may be entirely clear despite significant symptomatic dyspnea. So the negative predictive value of chest radiography is too low to definitely exclude heart failure. So it's a clinical diagnosis, heart failure. Now the measurement of the blood chemistry and hematologic variables in patients with heart failure. These are the list of factors that can be measured. But for diagnostic purpose, it is important is the natriuretic peptide. Others are used for evaluation for etiology and risk factors. Now, regarding the biomarkers. Biomarkers are now routinely used to distinguish heart failure patient from other conditions and establish severity of the diagnosis and provide useful prognostic information in heart failure. And these are the list of biomarkers, but all are not used in clinical practice. In clinical practice, only the natriuretic peptides are useful biomarker for heart failure diagnosis and estimation of the heart failure severity and prognosis. And the most frequently measured natriuretic peptides are B-type natriuretic peptide and NT-proBNP. That is it has been talked by Dr. Shamin. And these biomarkers are released from cardiomyocytes in response to stress. Now, imaging modalities for assessment of the heart failure. And these are the non-invasive cardiac imaging serves a vital role in assessment of the patients with heart failure because these are essential for determining whether the patient should be classified as heart failure with preserved ejection fraction, mid-range ejection fraction, or reduced ejection fraction. And imaging may help confirm the diagnosis of heart failure. For example, dilated cardiomyopathy. Now, these are the primary imaging modalities used in clinical, used for detection in heart failure. Actually, echocardiography, magnetic resonance imaging, computed tomography, and nuclear imaging. Echocardiography is widely and vastly used. It's a wonderful instrument, and transthoracic echo is an important part of evaluation of heart failure and can be performed without risk at the patient at bedside. It is well suited for evaluation of the structure function of both myocardium and heart valves and provide information about intracardiac pressure and flow. And it can be used for assessment of the systolic function and diastolic function of the heart can be done very efficiently. And for assessment of the systolic function can be done by semi-quantitatively, by eyeballing, or by modified Simpson's rule. Now, on the basis of the systolic function, the LV systolic function based on measurement of the left ventricular ejection fraction, the patient can be classified as heart failure with preserved ejection fraction more than 50, heart failure with gray area or mid-range ejection fraction. These have been talked by Dr. Shamin, that I am just repeating it, 40 to 49, and reduced ejection fraction is less than 40%. Another important function, diastolic function, can be assessed. It is using the Doppler measurement of the technique of the echo, the mitral inflow pattern of early wave and actual waveform, tissue velocities of mitral annulus, pulmonary vein flow, LV volume index to body surface area. Now, Diastolic dysfunction can be classified 1 to 4, but E by E prime is particularly helpful to determine the presence and severity of the diastolic dysfunction. And E by E prime is more than 15 is abnormal. And these are the list of E by E prime that indicate the pulmonary capillary waist pressure. That is E by E prime more than 15 indicate the PCWP is more than 20. That is LV EDP at least more than 16 millimeter mercury. So these are the list of E by E prime. How it does means the LV EDP, and this is by the courtesy of Dr. M.A. Masjid Khan. Now, lung ultrasound in heart failure, increasingly used to evaluate patients presenting with emergency department, useful to diagnose interstitial pulmonary edema, fluid overload through the detection of the vertical reverberation artifacts known as the curly B line. But this curly B line of lung ultrasound and curly B line in X-ray is a bit different. But I think in future clinical practice, lung ultrasound will play important role in deciding or for diagnosis of the clinical heart failure. So curly B lines may be highly sensitive and specific for presence of heart failure, particularly when incorporated with clinical judgment and other tools such as chest radiograph and natriuretic peptide. So this is the algorithm. I'm at the end of my lecture. Algorithm for diagnosis of the heart failure. I have taken it from guideline, ASC guideline 2016. These are the clinical history, physical examination, and ECG. The three components. If more than one component is present, then go for measurement of the natriuretic peptide. If it is negative, then heart failure are unlikely. And if all three are negative, then heart failure is absent, then heart failure is unlikely. But if more than one component is present, then and natriuretic peptide is positive, then go for echocardiography. That may lead you some etiological and hemodynamic assessment of the heart failure. So this is the end of my lecture. Thanks to all for patient sharing. Thanks, sir.
Thank you, Dr. Rahiduzzaman, for a very informative lecture on clinical feature and diagnosis of heart failure. Our next presenter is Dr. Abida Tasnim Reza. She will be talking on management of heart failure. Dr. Abida Tasnim.
Honorable panelist, respected moderator, my respected teachers, students, and dear learned audience, Assalamu alaikum and a very good afternoon. I'm Dr. Abida Tasnim Reza, Registrar, National Heart Foundation Hospital and Research Institute. Welcome you all on my topic, that is the management of heart failure. Let me start with two case scenarios. Case one, a 65-year-old gentleman presented with prior history of coronary artery disease and prior bypass surgery is now on maximum doses of carvedilol, ramipril, and spironolactone. He has recent history of hospitalization and still feels short of breath despite these three drugs. His vitals are within normal limits and ejection fraction is 32% at rest. Now the question is, what would be the next treatment plan in this gentleman and how to initiate the treatment? Case number two, a 53-year-old woman with a history of old myocardial infarction and chronic heart failure presents to the emergency room and she reports being short of breath. On examination, she is cold and clammy. Her blood pressure is 60/40 millimeter of mercury. She has tachycardia and tachypnea, and on auscultation of the lungs, there was bilateral crepitation up to mid-zone. So the question arises, what will be the approach of management in this lady? Hopefully at the end of my presentation, we will be able to answer all these questions. So the topics that I will be discussing are management of heart failure with reduced ejection fraction, management of heart failure with preserved and mid-range ejection fraction, acute heart failure management, and management of refractory or advanced heart failure. Now, each hospital should have a primary heart failure program, which should include primary care, general cardiology care, and advanced heart failure services. And heart failure management should always be multidisciplinary approach. Cardiologists, primary care physicians, and heart failure nurse, as well as other modalities of specialties, should also take part in management of individual patient. So what are the goals of our treatment? First of all, definitely improvement of clinical status, functional capacity, and quality of life. This is most important. Secondly, as these group of people have repeated hospital admission, our second goal will be to prevent repeated hospital admission and ultimately to reduce mortality. The treatment modalities include general management, pharmacological management, and interventional or surgical management. Now, American College of Cardiology and American Heart Association Guideline 2013 recommend that there is incremental addition of treatment as the heart failure progresses from stage A to stage D. And what about the general management? The foremost important is patient education as well as the education of relatives and caregivers. They should be explained the nature of the disease and treatment. They should adopt some self-help strategies such as daily weight measurement. And also patients should be educated regarding improved adherence to management. Now, what will be the diet of these patients? First of all, sodium restriction in all patients 2 to 3 grams per day and less than 2 grams in case of moderate to severe heart failure patient. Despite popular beliefs, fluid restriction is generally unnecessary. Fluid restriction less than 2 liters per day, specifically in hyponatremic patients or patients with fluid retention despite high doses of diuretics. And caloric supplementation is required in advanced heart failure and cardiac cachexia patients. Now, exercise. Generally, heavy exercise is not encouraged in this group of patients, but it has been seen that exercise reduces the morbidity as well as mortality in different randomized control trials. So, hospital supervised 12-week exercise training program followed by 25 to 30 minutes per day and 5 days a week home-based aerobic exercise on a treadmill or stationary bicycle is recommended. Other parts of general management include treatment of hypertension, diabetes mellitus, control of lipid, cessation of smoking, avoidance of alcohol and illicit drugs, avoidance of drugs precipitating heart failure such as NSAIDs, corticosteroids, and annual vaccination of influenza and pneumococcal vaccine. Several papers supports that this vaccination yearly reduces the hospital readmission. Now, the pharmacological management. The mainstay of treatment include AC inhibitors, angiotensin receptor blockers, beta blockers, mineralocorticoid receptor antagonists, diuretics, and the recent addition angiotensin receptor blocker neprilysin inhibitor, popularly known as ARNI. Except diuretics, all 5 have mortality benefits. And other treatment options include digoxin, ivabradine, hydrolyzine isosorbate dinitrates, calcium channel blockers, omega-3 polyunsaturated fatty acid, and recently sodium glucose cotransporter 2 inhibitors, that is empagliflozin, dapagliflozin. So as we have already seen the pathophysiology, these drugs act on different pathophysiological pathways and improve the symptoms as well as mortality and morbidity. Now, heart failure with preserved ejection fraction and mid-range ejection fraction are almost similar. So management of these two conditions are similar despite the different pharmacological treatment options in reduced ejection fraction. All the drugs that I have mentioned are important for treatment of heart failure with reduced ejection fraction, except calcium channel blocker, which is contraindicated. Whereas in heart failure with preserved and mid-range ejection fraction, the only 2 drugs that have shown some efficacy are diuretics and calcium channel blockers. Now, stage A and stage B, as we have already known, the stage E is our at-risk heart failure patients and B are asymptomatic heart failure patients. Can we prevent or delay the development of heart failure in these patients? Yes. AC inhibitors and beta blockers have shown to be effective to delay the development of overt heart failure or even prevent death before the symptoms onset. Now, what about the symptomatic patients? The symptomatic patients with reduced ejection fraction, we have to add two drugs simultaneously, AC inhibitors and beta blocker, and we have to achieve the maximum target dose. What about the maximum target dose? For example, if we start Riamipril at 2.5 milligram daily, the target dose that we have to achieve is 10 milligram once daily. And what about beta blockers? If we start carvedilol at 3.125 BD, the target dose we should achieve is 25 milligram BD. Now, if the patient is still symptomatic and ejection fraction is still low, so we have to add a third drug, that is mineralocorticoid receptor antagonist. And spironolactone starting dose will be 25 once daily, followed by target dose to be achieved is 50 milligram once daily. Patient still symptomatic, what we can do? Of course, if the patient is receiving ACV inhibitor or ARB, we have to replace the drug with ARNI. The paradigm heart failure trial has shown clear mortality benefit over enalapril, and we have to use this ARNI safe prescribing dose. That is, patient taking AC inhibitor, we ask the patient to discontinue the AC inhibitor 36 hours before starting ARNI, and in case of angiotensin receptor blocker, we ask them to stop for 12 to 24 hours. Now, if the patient is sinus rhythm, heart rate more than or equal to 70, we can use ivabradine. At this stage, we can also consider device therapy. During all these stages, if any time patient shows any symptom of congestion, we can use diuretics. Now, patient with all these drugs, if there is no symptom, we will continue the treatment. But if resistant, then we can consider other drugs like digoxin, hydrolyzine nitrate combined therapy, or N3-PUFA therapy. Some of the diuretics that we commonly use are loop diuretics, thiazide diuretics, and regarding the potassium sparing diuretics, we have to be very careful to adjust the dose along with the AC inhibitor or angiotensin receptor blocker. There have been several studies which shows that adding therapies is adding life. So there have been many guidelines, many references, but still, unfortunately, the most commonly prescribed class of agent is diuretics, and unfortunately, AC inhibitors and beta blocker, most of the cases do not achieve the target recommended dose. Now, what about the treatment options for heart failure with preserved and mid-range ejection fraction? No treatment has yet been shown to reduce morbidity and mortality in these two groups of patients. However, diuretics, calcium channel blockers, and management of underlying disease have shown some improvement of signs and symptoms. Now, there have been some relevant comorbidities that already been discussed that require particular medical attention, such as coronary artery disease, hypertension, atrial fibrillation, diabetes mellitus, lipid disorders, sleep apnea, which is important, depression, renal dysfunction, arthritis, anemia, COPD, liver dysfunction, cachexia muscle wasting, and electrolyte imbalance. Targeting some of the comorbidities will improve symptoms and improve the exercise capacity and quality of life. Now we move on to management of acute heart failure. The immediate goal of management of acute heart failure is to prevent the organ damage along with maintenance of oxygenation and also relieve the symptom of the patient. The intermediate goal will be to start the oral therapy and start titrating the doses. The pre-discharge and long-term management will be to enroll the patient in a rehabilitation program so that we can prevent repeated hospital admission of these patients and also to reduce the mortality among these groups. Now, how we can manage the acute heart failure patient. Patient with acute heart failure, definitely we have to position the patient in propped up position. We have to give high flow oxygen or adequate ventilatory support, try to identify the etiology. But very important is that we have to assess bedside very quickly the hemodynamic profile of this patient, whether there is presence of congestion or not. If the patient has features of congestion, either systemic or peripheral venous congestion, we categorize this patient as wet patient. If there is no sign of congestion, then these are dry patient. Secondly, we have to see whether the patient has adequate peripheral perfusion. If adequate peripheral perfusion, then we term them as wet and warm. Typically, they have elevated or normal blood pressure. If peripheral perfusion is inadequate, then these group will be wet and cold patient. Similarly, the dry patients are categorized as dry and warm patient and dry and cold patient. Now, wet and warm patient, they can be again vascular type and cardiac type. The vascular type where the hypertension predominates and cardiac type where the congestion predominates. So we can use in vascular type when there is hypertension, vasodilators and diuretics. These are the two treatment options. In congestion type, wet and warm patient, will start diuretics followed by vasodilators. Ultrafiltration is another treatment option in diuretic resistant case. Now, wet and cold patient, that is patient has pericongestion and also inadequate peripheral perfusion, whether the patient has systolic blood pressure less than 90 millimeter of mercury. First of all, we have to use inotropes and vasopressors. Diuretics we can use when the perfusion is corrected. And if the systolic blood pressure is more than 90, then we can use vasodilators, diuretics, and inotropes. Now, dry and warm patient, that means the patient having no congestion and adequate peripheral perfusion. These are actually compensated group. We should need to adjust the oral therapy only. But dry and cold patient, that is those having inadequate perfusion, these are hypovolemic patients. So we should consider fluid challenge as well as inotropic agents. These are the common vasodilators that we use in emergency and coronary care unit. So the refractory heart failure is my last management. So it is also known as advanced or stage D heart failure, which means presence of progressive or persistent severe signs of symptoms of heart failure despite optimal medical, surgical, and device therapy. Who are these patients? Those having repeated hospitalization in the past year, progressive renal deterioration, cardiac cachexia, intolerance to drugs like ACE inhibitors, beta blockers, all the symptoms of NIHA class 4, progressive decline in serum sodium, recent need to escalate diuretics. So what can we do in these group of patients? We need to restrict fluid. We consider continuous intravenous inotropes. We can use experimental drugs, and finally end-of-life decision like palliative care and hospice. So challenges in heart failure management is the ACE inhibitors and beta blockers is still remaining underused. Hyperkalemia and diuretic resistance may pose a challenge, and balance between improving symptoms versus improving prognosis is very difficult in these patients. Now let's move back to the case scenario 1, where there is elderly gentleman with chronic heart failure having 3 drugs at maximum doses, still feeling symptomatic. So what we can do in this patient? We can replace the ramipril with ARNI, and what we can ask the patient, we have to ask the patient to stop ramipril for 36 hours, then we will start ARNI. My second case, the 53-year-old woman with acute heart failure, and also she is tachycardic and her blood pressure is 60/40. So she will be categorized as wet and cold patient as she has congestion, features of congestion. And as the patient has less than 90 systolic blood pressure, we should initiate inotropes first with vasopressors, then we will start the diuretics. So before conclusion, I'd like to say that due to in a developing country like our Bangladesh, there is also financial restraints and also lack of resources. We should give more emphasis on general measures and prevention. Thank you all. Thank you for the opportunity. Thank you for a patient hearing.
Thank you, Dr. Abida. That was an excellent presentation on the management of heart failure. Thank you very much. So our last presenter is Dr. Khalid Mohsin, Associate Professor. He will be talking about the device therapy in the patients with heart failure. Dr. Khalid Mohsin, please. Can you share your screen? Unmute, please unmute yourself. Yeah, now you're audible, yeah.
Audible and visible as well?
Yeah, audible and visible clearly.
Okay. Okay. So, learned panelist, and dear participants and my co-speakers. I would like to recapitulate a very traditional word of wisdom from our pioneer and spiritual leader of cardiology of our country, National Professor Dr.S.M. Malik sir. As all roads lead to Rome, all cardiac disease, if not treated properly, will lead to cardiac failure, whether it is a congenital disease or an acquired disease. And my three previous speakers have very nicely elaborated every aspect of heart failure, starting from the pathophysiology, the clinical features, the investigation, and pharmacological management. It has left to me as a four-man relay race. The fourth person has the responsibility of crossing the finishing line as soon as possible. Actually, the non-pharmacological management, my previous speaker Abida has nicely said the features of the pharmacological management, aspect of pharmacological management, diet, nutrition, exercise. Only one thing I would like to add in her armamentarium, that a formal cardiac rehabilitation, it is very important in management of heart failure. And some of our Heart Foundation is also moving towards that direction, and a specialized heart failure department has been established in Bangabandhu Sheikh Mujib Medical University under the dynamic leadership of our beloved teacher, Professor Sajal Krishna Banerjee, and they are moving in the right direction. Let's recapitulate the other things which are left in the management. The devices which include implantable cardioverter defibrillator, cardiac resynchronization therapy, left ventricular assist device, impedance monitoring, transplantation, and other surgical approaches. The first of all, the most commonly used device after the pharmacological therapy, and it is very documented benefit in different clinical trials, is the cardiac resynchronization therapy. And it is a very important aspect in management of refractory heart failure. And though the cost is prohibitive and the technological aspects are sometimes very challenging, but in some patients it offers a ray of hope. This is we see there is a generator. It is it's a relatively big generator with 3 connectors. We can see clearly. One connector is for the right atrial lead, which is here in the right atrial appendage. Another lead in the right ventricular apex, which has got 2 coils in it, because in a defibrillator form it has coils, and in the pacemaker form, this is which we call the CRTP. They don't have a defibrillator coil. And another lead, which is the LV lead or the coronary sinus lead. It is also placed in the anterolateral aspect of the heart, and it helps to synchronize the chaotic ventricular activity in an orderly fashion, improving the cardiac output, decrease the mitral regurgitation, improves the electrical stability of the heart, and many other aspects. These are the indications of CRT. It's quite a simplified form. In a patient with heart failure with reduced ejection fraction and the need of a right ventricular pacing, this is a class 1 indication. If not, we consider the left ventricular ejection fraction as the hard parameter. If it is the less than 35%, we classify the patient according to the functional status. Mostly the patients of functional class 3 and 4, they are offered this therapy. And among this group of patients, if the QRS duration is more than 150 milliseconds, and the morphology, if it is left bundle branch block, it is a class 1 indication. If it is not a left bundle branch block, but it's still the QRS is very wide, it is a class 2A indication. If the patient has got an atrial fibrillation, the benefit is somewhat jeopardized, and the indication is class 2A. If it is a QRS duration of 130 to 149 milliseconds, if still it is a left bundle branch block morphology, as per the European guideline, it is class 1, but for the other guidelines, it is class 2A indication. And if it is a non-LBB morphology, this is a class 2B indication. If the patient is in functional class 2 and the QRS is more than 150 millisecond and the morphology is LBB, it is still a class 1 indication. It is a non-LBB morphology, it is class 2B indication. And the QRS duration, if it is as per the European ESC guideline, if it is the LBB morphology, it is class 2A indication as per other guidelines, and it is as per the European guideline, is class 1 indication. And if it is non-LBB morphology is with a narrow QRS, is a class 3 indication. And if the patient is in functional class 1, if the QRS duration is more than 150 milliseconds of LBB morphology with ejection fraction is less than 30%, it is a class 2B indication. Let's consider the patients in whom CRT is not a viable option in management, where the patient is unlikely to live for at least 1 year due to the comorbidities, and the heart failure patient with the non-LBB pattern, where it is a consensus particularly in the developing countries like us, where the patient has got a no LBB and the reduction, the QRS is less than 150. It's not very much encouraged. And in patients with a QRS of less than 120 millisecond, with only echo evidence of dysynchrony, it has been shown in some trials that if we choose the device on basis of only echo evidence, the most of the patient don't benefit. These are the summary of the findings of different clinical trials, including the class of evidence. It has been shown in many clinical trials that CRT is beneficial in terms of symptom and in terms of morbidity and mortality. There are some well-designed clinical trials like MUSTIC trials, which choose patients with more than 150 millisecond, the PATH CHF1 and 2, QRS more than 120 millisecond, Miracle ICD, QRS more than 130 millisecond, CARE heart failure, QRS more than 120 millisecond. They employed only the CRTP, the companion trial, QRS more than 120 millisecond. They all showed reduced all cause of mortality in patients with advanced heart failure who are refractory to medical therapy. And this group, in all these trials, the patient showed at least one NYHA class improvement of their symptoms. The MEDIT CRT trial, it's a trial, it's a comparison between CRT and ICD, 41% reduction in the first heart failure event, showed better response in women. Reverse trial, 53% reduction in first heart failure hospitalization. It favored the non-ischemic cardiomyopathy. Block heart failure trial, they showed better results with biventricular pacing compared to right ventricular pacing only. The REF trial, showed better result of CRT compared to ICD in terms of death and admission due to heart failure. The desired trial, the QRS in the enrolled patient with less than 120 millisecond with mechanical dysynchrony or on echo, the predicted response. The esteem CRT, they were selected on the basis of tissue Doppler imaging. The patients all had a narrow QRS. They showed that no significant favorable response with CRT. The echo CRT, they employed mechanical dysynchrony, and they also didn't show much benefit in a patient with QRS of less than 120 millisecond. The PACE trial, the RV apical pacing leads to LV dysfunction, and in a patient with bradycardia, in a patient with LV, jeopardized LV function. So CRT was clearly the therapy of choice. The BioPace, it showed that the biventricular pacing is better than RV pacing in a patients with atrioventricular block. The ICD indication, there are the two types of indication, the primary prevention and the secondary prevention. The secondary prevention are the well documented. They have the survivors of cardiac arrest, the sustained VT which cannot be ablated, syncope due to complex ventricular arrhythmia. They are all, they are conclusively, the ICD is indicated. And in cases of primary prevention, these are the patients who are not eligible NYHA class 4 because they are liable to pump failure, the cardiogenic shock, revascularization within last 3 months, or the patients are waiting for coronary revascularization, irreversible brain damage, and other causes which jeopardize the 1 year survival of the patient. This sort of patients should be excluded from ICD therapy. And in case of primary prevention, the MI which have 40 days have been passed after an MI, and the ejection fraction is significantly low. In less than 40 days of after MI, it is better to manage the patient medically and reassess after 40 days. And in the patients who have ejection fraction less than 30, but 40 days have elapsed after MI, they are NYHA class 1. They have to be recommended for ICD therapy. And if the patients are NYHA class 1 to 3, they have non-sustained VT, prior MI, and inducible VT and VF by EP study. They have they are class 1 candidates. And NYHA class 2 to 3, they have to be considered for ICD implantation as well. And those patients who have a QRS of more than 150 millisecond and the LBB, they should be considered for CRT implantation. So the primary prevention, the evidences are not that robust, but in cases of secondary prevention, it is a very robust clinical evidence are in favor of ICD implantation. In what are those patients where ICD are to be avoided? NYHA class 4 patients who are not expected to improve with therapy and who are not candidates for cardiac transplantation or mechanical circulatory support. The patient with coronary artery disease, LV systolic dysfunction, and recurrent hospitalization for heart failure, who should probably not receive an ICD as their survival is likely to be very much jeopardized due to pump failure. So the arrhythmic death is not a very important consideration in this group of patients. And patients with significant LV dysfunction, but they don't have high risk features of sudden cardiac death like complex arrhythmia on Holter or inducible VT and VF by EP study. So they are not the classical candidates for ICD implant. Many studies have evaluated the benefit of ICD, the Dynamite, the CABG patch trials. They did not show much benefit of ICD as a primary prevention measures in a patient with severe LV dysfunction. But these two studies, MEDIT2 and SCD heart failure trial, has shown that ICD has reduced overall mortality as a measure of primary prevention. The mortality benefit was about in cases of in 14.2% with ICD and 19.8% with optimized medical therapy. The p-value is significant, and the sudden cardiac death reduction is also significantly lower. And the meta-analysis showed the different trials that in secondary prevention the results are quite robust, and the reduction of overall mortality about 28% and arrhythmia related mortality about 50%. But we should not forget that the medical therapy is also quite good. Like the ACE inhibitor can reduce mortality by 6.1%, beta blocker by 4.4%. Aldosterone antagonists also, they are quite helpful in reducing mortality. Then after the implantable, the pacing devices or the ICD and CRT, the other options are the intra-aortic balloon pump, which are used commonly in the coronary care unit, cath labs, and as well as in the operating theater and post-operative period. They augment the coronary flow and they reduce the afterload. But they are largely being replaced by Impella, though it is a very costly one. The Impella 2.5, Impella 5, Impella recovery, and the cheap cases, mainly the high risk intervention, is being done under support of Impella, though unfortunately this device is not available in our country. ECMO, its use has been highlighted in the COVID era, particularly the refractory hypoxia with cardiac function deterioration. The ECMO is a very good choice. The left ventricular assist device, they are implantable devices for quite a prolonged support to the heart and circulation, and they are bridge to the procedures, and they can prepare a patient for cardiac transplantation as well. These are the indications of induction of mechanical support: frequent hospitalization for heart failure, NYHA class 3-4 symptom with maximal therapy, and NYHA, then the intolerance to commonly used medication, the increasing diuretic requirement, symptom in spite of CRT implantation, dependency on inotropic support, the low peak oxygen consumption, and end organ dysfunction, which may be due to low cardiac output. In this group of patient, we should actively consider the mechanical support. There are some contraindications of mechanical support as well. Some of them are absolute, like the irreversible hepatic dysfunction, neurological dysfunction, severe psychological limitation, like then the non-adherence to therapy, the relative contraindication, advanced stage, advanced renal impairment, the obesity, malnutrition, the impaired musculoskeletal disease, which limits the mobility of an individual, the systemic infection, uncontrolled systemic infection, the prolonged mechanical ventilation, malignancy which likely to jeopardize the longevity, peripheral vascular disease, substance abuse, cognitive dysfunction, lack of social support. These are the relative, absolute and relative contraindication of mechanical support. The Impella is a very attractive option in mechanical support. It is very easy to install and easy to withdraw, but the prohibitive aspect is the cost. It is a catheter-based pump, which the pump is inside the ventricle, and it propels the blood to the aorta, aortic valve, and to the aorta, and it improves the ventricular performance and give rest to the left ventricular musculature and helps it to recover if there is a reversible cause of myocardial dysfunction. And it is a very good adjunctive in high risk coronary intervention in the cath lab, particularly the chip cases. Left ventricular assist device are surgically implanted devices. These are also a pump which can support the circulation on a temporary or a permanent basis to augment a failing heart. The principle is to divert the blood from the failing ventricle and to rest the ventricle, but maintaining the cardiac output in an alternative manner. So how does it work? There is an inflow that collects the blood from the left ventricle, and the blood is passed to the pump, and the blood is delivered to the aorta, and thereby bypassing the ventricle and giving rest. And the inflow and the outflow component are placed surgically inside the pericardial cavity, and a electrical line which exists through the iliac fossa and connects to a rechargeable battery. And we have seen in the social media that the patients are quite mobile. They carry the battery and the pump, and they lead a quite an active life, but with some limitation of activity. So how the LVAD use has got 4 aspects. Number 1 is a bridge to transplant for end-stage heart failure who are waiting for a donor heart. As we all know, the donor heart is quite difficult to get. So, and as a destination therapy, it is the final therapy for them who are not candidates of cardiac transplantation due to various contraindications. Will come later on what are the contraindications of cardiac transplant. And a bridge to cardiac transplant, when initially the patient is very sick, but with this device the patient may improve functionally and be a candidate of cardiac transplantation at a later period. And it is can be used as a bridge to recovery, like patients with severe myocarditis, and this support can help the patient recuperate from the myocarditis. And following recovery, this device can be removed from the body. Here, this is the heart, and here is the collection point from left ventricle, and this blood it is acting as an inflow to the pump, and this pump is delivering the blood to the aorta. And this is a shoulder strap, and the battery is here, and the electrical this is a rechargeable battery, and it is delivering the current to the pump. So this device, it schematically looks simple, but it is quite cumbersome to carry this device. And the common one used here in the popular devices are HeartMate 2 and 3. These are approved by the FDA and the ESC. This is another view of this device, the collection from the LV and delivery to the aorta, giving rest to the left ventricle, which is the dominant ventricle. And left ventricular assist device, it is a class 2B indication. There is another technique which is used as a mechanical augmentation of diastolic coronary flow. This is the EECP. This can be employed in cases where the options of revascularization has been exhausted and the transplantation or the LVAD is not feasible, particularly in very hopeless situation. Some patients do improve during the procedure. It is a 6-week therapy, but after the procedure is over, the patient's symptoms tend to recur. So it is not a very viable option. And another is the shock wave therapy, like the ESWL. It helps to the growth of collaterals in the heart. It is also an option, but it is not that scientifically recommended. Coronary revasculation is an important aspect of refractory heart failure when there is a viable myocardium, as 80% of the patients of heart failure have coronary disease. And in this group of patients, we must be sure of the viability of the myocardium. The non-viable myocardial, if revascular intervention or surgery, is not going to help the patient. So it has to be evaluated very meticulously by cardiac MRI or the myocardial perfusion imaging, and then revascularization should be undertaken. These are the surgical option, but not used commonly nowadays. The cardiomyoplasty using the latissimus dorsi wrapped around the heart, and the reductive ventriculoplasty, reducing the diameter of LV and reducing the myocardial wall stress, the Batista procedure. These are almost abundant. And the valvular replacement and repair is a very important aspect of treating end-stage heart failure. As the LV dilates, if even the valve is morphologically normal, significant mitral regurgitation can develop, and the ischemic MR up to certain extent can be corrected by revascularization, but if it is severe, the mitral valve repair or replacement needs to be done. And the interventional procedures like mitra clip, TAVR, it can be done where the surgical risk is too high for the. And this is the cardiac rehabilitation, cardiac transplantation. The indications are patient persistently invasion class 4. The patient failed to manage improve in more than 45 days, and the intra-aortic balloon pump has been given for more than 7 days, and the inotrope dependency for more than 14 days. EF is less than 25%, and the peak oxygen consumption is less than 14 ml per kg per minute, unless the patient is on a mechanical device. And this in this group of patients who are the age should be less than 60 years, no life-threatening comorbidities. At least the patient is expected to survive at least 1 year. So these are the patients who can consider for cardiac transplantation, and some patients who are at a point of time are unsuitable but may improve with LVAD, left ventricular assist device. The cardiac transplantation, the 1 year survival is about 90%, and 10-year survival is 50 to 60%. And these are the comorbidities we don't expect to find in a potential transplant recipient, like end-stage renal disease, severe pulmonary hypertension, severe liver disease, life-threatening malignancy. These are the exclusion criteria. These are the summary of the surgical procedures which are likely to help a patient with heart failure. The heart transplant is the final therapy, the mechanical support, revascularization, ventricular reconstruction. The LV aneurysm repair is also one of the most important aspect. And these are the myocyte restoration, the stem cell therapy, but the efficacy is doubtful. The mitral valve reconstruction, these are the myosplint and the cardiomyoplasty. These are the are of historical importance. So the surgery plays an important role. And another thing, among the interventional procedures, the mechanical complication following myocardial infarction, like the ventricular septal device closure, is also a very important aspect of treatment, because these patients are going to intractable heart failure and pump failure in the very short and intermediate term. These are the analogy of the donkey and the cart. The donkey, if the load of the cart is it's beyond the capacity, the donkey gets tired and becomes exhausted. So to get the donkey going, we have to limit the speed, or we have to reduce the load, already described by the Dr. Abida. And so by reduction of the load, the efficiency of the donkey can be improved. We can stimulate the donkey with some food or something like that to help to stimulate to work better. And we can put some device in the donkey's feet, like the roller coaster, and these roller coaster is the devices to improve the efficiency of the donkey. And we must consider that the heart is a very fragile organ, and we must extend utmost care to the heart. The cardiologist, interventionist, cardiac surgeon, they should handle the heart with much care. And thanks for your patient hearing. And
Thank you, Dr. Khalid Mohsin. That was elaborate discussion on device therapy and heart failure. We are glad that Professor Sajal Banerjee has joined us. Sir, are you there? Sajal Banerjee, sir, was there. I think he left again. Okay. So I think after a long discussion, we should have some talk. So let's start with Professor Meshkat, Chaudhry Meshkat. Meshkat bhai, please comment on all the discussion, please. We have got a few questions, but I think we'll discuss later. First, let's our Meshkat. Unmute, please, unmute.
It is an immense pleasure to be with National Heart Foundation, not because all great people are there, but also because that I can learn so many things from the presentation. All the presentation that I have attended so far was so rich and so well designed and so beautifully being presented. I'm really spellbound with those presentations, and I have learned so many things. The presenters had been excellent altogether.
So any comment about the management and anything?
Yes, and of course I have got a comment on the management and little talk about the HFPF, which is now a really hot debate, and a lot of information are really coming over last few months, and a lot of information are going to come in next year. We have some newer drug which are really being very effective, like SGLT2 receptor. In recent Congress on heart failure by American Heart Association, they have recommended, and they have understand the values of treating the heart failure with 4 drugs, because we knew there had been 3 pathways: the angiotensin pathway, the mineralocorticoid pathway, the sympathetic pathway, and we also came to know about the neprilysin, that is peptide pathway, and now we know about the sodium glucose co-transporter pathway. All these 4-5 pathway actually, they work parallel. They do not really exceed the limit of one and another. So maybe it can be wise for a refractory cases to use all the 4 drugs together. We know the beta blocker will act on the sympathetic, will act as sympathetic blocker, the angiotensin receptor as angiotensin receptor blocker, the mineralocorticoid receptor blocker also will have. We have the neptolysine, which will block the peptide pathway, and SGL2 has got different pathway to act upon. So by using ARNI, we can block the both angiotensin and the peptide pathway. So there are 3 drugs for 4 pathway, and we now have an extra pathway. Maybe we will be able to use that. In next year, things will be more clearer, but many results, especially the Pioneer 2 result and the paradigm studies, all studies have shown if not only for the severe cases, not only for the refractory cases, if you can use ARNI in patient who has been hospitalized or who has got the hospital admission for the first time, probably they are also the candidate for ARNI instead of only angiotensin or ACE receptor blocker. So in next 6 months, many interesting things will be done in the arena of treating the heart failure. We will have to be watchful about that, because after all this modern treatment, after optimizing all the drug and the devices, still the mortality for the heart failure is more than 15% in stable cases. It is more so in unstable cases. So we need to do a lot more on the treatment of heart failure. As regard investigation, lung ultrasound is quite attractive choice. It's very simple to use, very simple to learn. And one of our students are doing work on that. The B line are very easy to find out. We can use it in our day-to-day practice. In echocardiography, we also have to look at many more parameters that can help us in deciding some therapeutic option. For example, if we have to also look at the right ventricle and the pulmonary hypertension, we can really tell about the prognosis of a patient with heart failure. So echocardiography and the strain, the study of strain also gives some focus on the etiological origin of the heart failure. So nowadays, echocardiography has much more extended role for heart failure. As regard preserved ejection fraction, it is a completely different entity, although some people do not agree that this is a different entity. But our experience in BSMMA, my personal experience as echocardiography, it exists. But there is different genetic, there is genetic heterogeneity, there is phenotypic heterogeneity, and there is therapeutic heterogeneity as well. We today, today, we say that we do not have any treatment for HFpEF. But if you look at the Paragon study and also the Paradigm study carefully, the patient who were left in the mid-range zone and the female patient, they really derived some benefit from the ARNI treatment. And in TopCat study also, the mineralocorticoid receptor antagonist had some beneficial effect on HFpEF when the patient were remaining in the mid-range ejection fraction. So within the study, we have many subtypes of group of people who can be benefited with different form of treatment. So treating heart failure is going to be one of the state of art, very fine state of art. And for that, we really need to have a specialized heart failure unit. And there is an interesting trial as well for HFpEF, so long device is concerned. So there is a study which is looking at the communication between the right atrium and the left atrium to decrease the load of the left atrium. The trial is on horizon. The decreasing LAP is the trial. So it will be look at if we can make an interventional shunt between left atrium and the right atrium by decreasing the left atrial pressure, whether the longevity of patient with left ventricular HFpEF will be improved. So a lot more things, interesting things are going to be observed in the next year. These are all my comments about heart failure.
Thank you, Dr. Mishkat. That was excellent discussion about heart failure. I have some I have a query, Dr. Abida, regarding the use of ARNI. I think the European Society and American Heart Association, they have got different way of using it. One group they want to use ARNI from the very beginning, upfront,
Yes, sir.
and another group they use ARNI only resistant case. So which one you favor? Which one is better? Either to use ARNI upfront or to wait for the resistant patient then use ARNI?
So actually, yes, the updated focus update of SCAHA 2017 shows that we can start ARNI from beginning. And another thing is the ESC guideline showed that we can use ARNI depending on the NT-proBNP. That is, if the patient's NT-proBNP is more than 150 picogram per ml, BNP more than 150 picogram per ml and NT-proBNP more than 600 picogram per ml, and patient is hospitalized in last 1 year, even once, then we can start ARNI depending on this BNP level. And so in that case, we can use ARNI if depending on the patient's proBNP and NT-proBNP level. And another thing is regarding the cost effectivity, in our country as Ramipril and these AC inhibitors are widely available and these are cost effective. So in our Bangladeshi perspective, I think, sir, you can tell that from experience, like whether we can use ARNI from the beginning as thinking about the patient's financial condition.
Thank you. Regarding SGL2 receptor blocker, so
yes,
what is your take on this SGL2?
Yes,
already,
sir.
Professor Mistat has already mentioned
Yes,
about
sir.
it.
Yes,
How
sir.
it's the pathway of sodium glucose transport pathway. Yeah.
Yes, sir. As it works in the proximal convoluted tubule, this sodium glucose co-transporter 2, that is inhibitor, that is already, there is recommendation in ESC guideline in stage A and stage B heart failure that it shows that it prevents heart failure symptom by treatment of diabetes mellitus. It is already in the guideline. And recently Lancet has published several papers where it shows that in DAPA heart failure trial, they have seen that irrespective of diabetes mellitus present or not, the SGL2 inhibitor has shown morbidity and as well as mortality benefit. But the thing is, still the results are yet to be confirmed whether it has long-term values. So we can wait, but it can be an important alternative and also an important addition in the recent future.
Thank you, Dr. I have one query to Dr. Khalid Mohsen regarding the use of CRT in a patient with non-LBBB. Actually, nowadays, a good number of patients with non-LBBB white complex tachycardia are getting CRT with little benefit, actually. Yeah. And recently, I have attended a lecture, international lecture. They have said that non-LBBB, even if it is white complex, is not going to help with CRTD. Even they have said that LBBB with non-ischemic cardiomyopathy is highest responder. Non-ischemic cardiomyopathy with LBBB, white complex tachycardia, they are the highest responder. But nowadays, even the RBB with 0.14, we are placing CRT with very little response. So what do you take? Should we continue like this? Because this costs a lot for the patient and we find little benefit for the patient. Even the guidelines doesn't support it.
Yes. Okay, thank you, Professor Rahiduzzaman, for a very, very pertinent question. Actually, in patients with the refractory heart failure, our goal is to improve their quality of life. That is the main thing, and their longevity is definitely is a second on the priority list. Actually, so we all know that the ICDs, you cannot contribute in improving the quality of life of a patient, but CRT does. But as there is quite a gap in the expenditure between ICD and CRT, so we have to consider the cost. But in some cases, when the RBBB is a very wide QRS complex, in sometimes we give the ICD, we give the CRT in particularly in cases of non-ischemic cardiomyopathy. In this group of patients, we can offer them the CRTP the cost is quite less than the CRT-D. And in this group of patients, it's a class 2A indication if the QRS complex is more than 150 millisecond. And in this group of patients, we give them as a benefit of doubt, and we program the device in a separate way so that the ventricular activation sequence is changed. And if we can program the device in a very according to their need, I think some of the patients they improve. In particularly the non-LBV patient. Dr. Ashok Datta is with here. He has got quite a significant experience in implanting the devices. Any comment, Dr. Ashok?
Ashok, regarding non-LBV patients.
Thank you, sir. That is really what you are telling, that in RBB with wide complex, even if it is more than 150, response rate is poor, especially in ischemic cardiomyopathy. But in non-ischemic cardiomyopathy, overall CRT resynchronization got a better result. That is true for LBB with RBB with wide complex also. So in that case, sometimes they recommend 2A, somewhere 2B, because there is no other way. Very resistant to all anti-failure therapy, even with ARNI, diuretics. In that case, that may be the only hope.
Last hope. Yeah.
Exactly, sir. I have got one question regarding ARNI. That is a very, as far I have using many cases, very potent antihypertensive, sir. So and also the EMPI and DAPA, that with other antihypertensive that I think has got synergistic effect because of his diuresis. Many resistant patient with glipizide or DAPA, they reduce the blood pressure very rapidly. Other thing is ARNI, can it be used? Can it be used in patient with resistant or nearly resistant hypertension with LV hypertrophy? There is risk of heart failure. Like many patients with this type of patient, resistant hypertension, LV hypertrophy, gross hypertrophy, LV has got class 2 symptom. So ARNI can we use in that cases as an antihypertensive, as an anti-failure, or as an what Rahiduzzaman sir was telling?
As a preventive measure, right? So as a preventive measure.
Preventive as well as antihypertensive.
এটা শামিম দেখালো যে ক্লাস stage 1 যেখানে patient is not NIH 1 nor NIH 2, but patient is potentially at risk of heart failure, developing heart failure. Otherwise, patient is at risk of developing heart failure but has no symptoms. In that case, I don't think till now there is any study which suggests that ARNI can be used at this stage, which may prevent heart failure or progression up to heart failure. Another question to Dr. Ashok Datta or Dr. Khalid Mohsen, please, regarding the another procedure that's called CCM, cardiac contraction modulation. Do you know about it? Cardiac contraction modulation. These are for the patients with narrow complex tachycardia, narrow complex non-LBV patient who are not responding to CRT. The CCM is coming up with a new modulation, which they are saying that they are responding much with CCM. Dr. Khalid Mohsen, I think.
Yes, this is an option. This is one of the, it is called the multi-site pacing modality. Actually, the RV is paced at different sites in the patients who have LV dysfunction and without the favorable QRS morphology. So in this group of patients, they can be benefited by multi-site pacing, 2 or 3 sites they can, but it's still not commonly used in clinical practice nowadays. And another option is in patients who are pacing dependent, the His bundle pacing also is beneficial because the deterioration of LV function can be prevented by using the normal electrical conduction pathway. Because even if we pace if we avoid the RV pacing by pacing the septum, this is relatively better, but it is not free from all the disadvantages of RV pacing. But in this group of patient, his bundle pacing by using a specialized lead system is beneficial. I think Ashok can add something on this.
Yes, sir. His bundle pacing and left bundle branch pacing. These two are nowadays very hot topic. And someone telling that LV pacing or CRT will be replaced by atrial pacing and his bundle pacing or left bundle branch pacing. So that produces the QRS complex as narrow as normal and synchronize the LV and RV contraction. So that is sometimes as an alternative CRT or dual ventricle biventricular pacing. Last ESC in a session, I have seen that an Italian person always he used to pace the right atrium and his bundle. If failed, then left bundle. And if his bundle or left bundle pacing failed, then he used to do the left ventricular plus right ventricular pacing. So this is his all the cases, more than 100 cases. He did like this. So this is the now to him CRT is the last option when his bundle or left bundle branch pacing is failed. But a lot of disadvantages is there, like lead loss is one of the complication that may happen.
Thank you, Dr. Ashok. Dr. Dhiman Bonik, are you there? Dhiman, it's not there. So we are already too late. Professor Fazila Malik, Madam, are you there?
I am here. So thank
please,
you.
So can you make some final comments about the session?
This was a fantastic session. I learned such a lot, and our panel of experts was excellent and great moderation by you. It was very diverse, lots of knowledge, great presentation. Thank you so much. Really enjoyed the whole session.
Thank you. Thank you very much for Professor Mishka, I think you have some final words to say. You got someone to add something last.
Yeah, maybe I'll take a little time. There was a breakthrough study known as Pioneer Heart Failure Study, which shows after the patient is readmitted for heart failure and he has been stabilized, but within 2 months of discharge from the hospital, there was a study in one arm, there was ACE inhibitor, and in another arm, there was ARNI. In initial 2 months, there was marked reduction in mortality. So other than the refractory heart failure group of patients who are readmitted in the hospital, may be a good candidate for ARNI, at least for 2 months, because this study has been an elegant study and its implication is quite high. There are 2 other drugs are there in the horizon. One is
irrespective of the ejection fraction, sir. This is all patient irrespective of ejection fraction.
Mortality benefit.
I'm telling that all the
mortality benefit was
ejection fraction there. So all
the
primary patient with ejection fraction, low ejection fraction, normal.
These drugs are only you can apply when the patient's hemodynamics can permit. Also, there are 2 new drugs. One is vericiguat and the aminocarbate mecarbil. Both these drugs also may have different mechanism, especially myosin chain activator, that is inotropic drug. And when in many cases we cannot apply the doses in up titrated dose because of low blood pressure. So they are the option when we have low blood pressure and we still have the refractory heart failure, then we can vericiguat and the that is myosin light chain activator. These are the options are being recommended. We can really apply those. But heart failure is a heterogeneous group of people, and we really have to individualize each patient. And we have to learn about the art of treating each patient separately. For example, many cases in our refractory heart failure, we add thiazide with furosemide, and that acts. We also have in our Armnam and the ivabradine. That also works to some extent. And in some patients with right heart failure, with severe ascites, heavy dose of spironolactone does the trick for them. So different patient with different heart failure has got different therapeutic implication. Thank you for giving me the space.
Thank you, Professor Mishkat. Khalid.
Just before you conclude, I would like to have your opinion of Fazila Madam regarding, are you missing the impeller device when you are doing very high risk complex?
Well, actually, I mean, impeller sounds very good theoretically, right? But I don't know whether I'm missing it. In certain situations, definitely, but the expense is so much, isn't it? So
Beyond our, yeah, it's too
very
expensive.
expensive. And the other thing is, this device cannot be used in many patients. Like, who are the most sick patients? The most sick patients are those who are very frail, who have usually peripheral vascular disease, and you might have a challenge even taking the impeller up, right? So maybe you would have to use it through the axilla or something. But definitely, Khalid Mohsin, this is a very relevant thing. I think in our center we should, and also in Bangladesh, impeller, if it comes, maybe it might make a difference, because for very high risk patients. Yeah, thank you for the comment.
Chief Minister of Tamil Nadu, she was given impeller when she was in the last stage of her.
Yeah, but she didn't make it. She died, right?
She died. Yeah, she died. So actually, yeah, it's an excellent device. Only you have, as you have mentioned, that the problem is with the cost. It's a very high cost, and it cannot be used. That's the problem. So thank you very much, everyone, all the panelists, Professor Mishkat, and all the presenter. Announcement: we don't have any presentation next Wednesday because of our annual conference. So our next session will be on the 9th of December, Wednesday. Till then, goodbye and good luck. Have a nice sleep. Good night.
Good night.
Good night.
Thank you, sir.
Thank you.
Good night.